This is a condition actually where excess and prolonged deficiencies in vitamin D softens and weakens the bones and make them more likely to fracture. Rickets is a condition that affects bone development in children, as I already mentioned, resulting in bone pain, poor bony growths, and weakness in the bones and proximal muscle weakness as well. As mentioned earlier, it's caused by vitamin D deficiency. Vitamin D, if you recall from the physiology, vitamin D is required for the absorption of the calcium from intestine, and calcium is responsible for the mineralization of the bone. How the calcium and phosphate is regulated, we will discuss over here. Peak bone mass is achieved at the age of 16 to 25 years. Bone loss occurs at a rate of 0.3 to 0.5% per year. 2 to 3% per year after 6 decades, where is accelerated bone loss. What are the pillars involved in this? Are parathyroid hormone, vitamin D, calcitonin, and other hormones, estrogen, which prevents the bone loss. As we see in postmenopausal female, it leads to osteoporosis. Corticosteroid increase bone loss. Thyroid hormones lead to osteoporosis, and growth hormones cause positive calcium balance. Normal bone metabolism, calcium is deposited almost in total 99% in the bone. Main function, muscle nerve function, also function in the clotting as a factor. Plasma calcium, 50% of the free and 50% is in the bound state. Dietary needs vary according to activity and age. Kids need 600 milligram per day. Adolescent 13 is mean average, but it varies from 1,000 to 1,400. Adults 750 to 1,200 milligram actually. Pregnancy, we have higher needs, 1,500 milligram per day. Breastfeeding up to 2 grams per day, and if someone has already sustained a fracture because of softening of the bone, then 1,500 milligram per day. Calcium is absorbed in the duodenum and jejunum. 98% reabsorbed in the kidney. Proximal tubule may be excreted in the stool. Normal bone metabolism. Phosphate is 85% in the bone, functions metabolite and buffer in enzyme systems. Plasma phosphate mainly unbound. Daily requirement is 1 to 1.5 gram per day. Here is the slide which shows you how the calcium is absorbed. Dietary calcium that we take orally goes to the intestine, where calcium and phosphate is absorbed and goes into the extracellular fluid. Calcium and phosphate is tightly regulated by the activity of the parathyroid hormone. Vitamin D, as we see here, the vitamin D is required for the absorption of the calcium from the intestine. If, say, for example, a person is deficient in vitamin D, then what happens? Calcium is not adequately absorbed. When the calcium is not adequately absorbed from the intestine, serum levels come down. When the serum levels of calcium come down, there is feedback mechanism of parathyroid hormone, which increases its secretion. So parathyroid hormone released in excess. Because parathyroid hormone has a responsibility of maintaining serum calcium levels, irrespective of where it is coming from. So if the dietary calcium is unavailable because of vitamin D deficiency and the levels are low, then parathyroid hormone actually causes the catabolism of the bone osteoclast activity and releases the calcium from the bones and to maintain the serum levels. But as a result, what happens? Bones become fragile, brittle, and easy to fracture. However, this is for sustaining life, because low calcium levels in prolonged may interfere with cardiac activity, and even arrhythmias and death may occur. So at least the parathyroid hormone is maintaining the serum levels, maybe even at the cost of your bones, but at least it saves your life. So parathyroid hormone regulates also conversion of 25-hydroxy to 125-dihydroxy in the kidneys, which actually is the active form and least absorption of the calcium. Calcium deficiency causes hypophosphatemia, defect in vitamin D metabolism, and nutritional causes like diet, oily fish, eggs, breakfast cereals, antacid abuse causing reduced dietary phosphate binding. Under exposure to sunlight also leads to calcium deficiency in osteomalacia, vitamin D deficiency. Elderly individuals with minimal sun exposure or dark-skinned people. Other causes defect in vitamin D metabolism may be related to their male absorption and gastrointestinal diseases like celiac disease, intestinal bypass surgery, post-gastrectomy, chronic pancreatitis leading to malabsorption, biliary disease leading again to reduced absorption of the vitamins because bile is needed for the absorption of fat-soluble vitamins, and any other small bowel disease. Other causes defect in the vitamin D metabolism like liver failure. As we know, first hydroxylation of the vitamin D occurs in the liver, while second hydroxylation occurs in the kidneys. Fat metabolism, malabsorption syndromes, kidney failure like renal tubular acidosis and renal ester dystrophy are other causes of defective vitamin D metabolism. Some drugs like anti-epileptic phenytoins, sodium valproate may cause vitamin D deficiency, and genetic cause as well. What are the symptoms and signs of osteomalacia? Bony pains, backache, muscle weakness, vertebral collapse leading to kyphosis, loss of height, and deformities and stress fractures may also occur in patients with osteomalacia. Osteomalacia in adults starts insidiously as aches and pains in the lumbar region and thighs, spreading later to the arms and ribs. Pain is non-radiating, symmetrical, accompanied by tenderness in the involved bones. All these occurs because we know because of osteomalacia is the suffering, vitamin D is absent. As a result, what happens? Parathyroid hormone acts upon your bones, tracks the calcium from the bones and brings to the serum level to maintain serum levels of calcium. And as a result, bone becomes weak and they cause pains. Proximal muscle weakness, and there is difficulty in climbing stairs, getting up from a squatting position with prolonged osteomalacia. How to diagnose osteomalacia? Blood test. Decreased serum calcium, phosphorus, or sometimes may be normal at the expense of parathyroid hormone activity. Serum calcium, in many cases, you may find normal to low serum calcium levels, and phosphorus. Phosphorus levels is low again because of the action of parathyroid, because parathyroid hormone excretes the phosphorus from the kidneys until unless there is kidney failure, in which case you may have hyperphosphatemia. Otherwise, decreased normal calcium levels and low phosphorus levels are hallmark of the osteomalacia. Decreased vitamin D and elevated alkaline phosphatase, bone origin alkaline phosphatase increased. In children, we see growth palate widening or thickening, cupping or fraying of the radial radius and at the wrist joint. Diaphyseal deformities may also occur. In osteomalacia, you may have loser zone or pseudo fractures, what we call biconcave vertebrae, proteroacetibuli. I will show you the pictures, radiological pictures later. And spontaneous fractures may also occur. Pillar signs of secondary hyperparathyroidism may be there, hypophosphatemia and bony pains. And deformity like Rugger jersey deformity in the spine, as you see. Here you can see incomplete stress fractures with healing, lacking calcium, on compression side of the long bone. Here it is. This is looser zone or pseudofracture, can easily be seen. We have a regular jersey appearance of spine, and then trefoil pelvis due to indentation of acetabular secondary stress fractures. I am showing you the trefoil pelvis over here. This is not trefoil fracture. This is looser zone in the hip. This is trefoil pelvis, and it has so many consequences, especially in the females during childbirth, because of low pelvic cavity, biconcave vertebral appearance, like fish mouth appearance, what is typically called fish mouth appearance, or the radiological hallmarks of osteomalacia. How to treat osteomalacia? With the adequate vitamin D supplementation, adequate exposure to sun can avoid the development of osteomalacia. In the diet, should be rich in milk, yogurt, and cheese, contain good amount of calcium and vitamin D. Dark green leafy vegetables, broccoli, fish and seafoods also contain a good amount, and almonds. Osteomalacia treatment. This is the daily low dose requirement, but we need to get vitamin D levels as well. If vitamin D levels are low, then we need to give mega units of vitamin D to the patient in order to replace the deficiency. Then can be kept on the maintenance doses. The normal values are in the adults are 30 milligram per deciliter and above is kept in their serum of vitamin D levels. If it is between 20 and 30, this is insufficiency, and between 10 and 20, it is deficiency, and less than 10, severe deficiency. So we replace according to the level of baseline vitamin D. Calcium supplementation is required, initially 3 grams, but then at the maintenance doses of the patients having hypocalcemia. Once calcium serum levels are normalized, then daily calcium requirement will be from 800 to 1200 milligram per day. If because of the softening of the bone, any fracture occurs, then orthopedic is involved and fracture management is done. If there are any deformities that needs correction, probably orthopedically. Moving to the next topic, osteoporosis. Now this is again, osteo means bone, porous means porous bones. There is increased porosity of the bones, resulting in easy fractures. This is by low bone mass or density with a structural deterioration of the bone tissue, leading to fragility or low impact fractures, commonly of the spine, hip, and wrist. Until a fracture occurs, this condition is usually silent and usually a painless condition. If someone is having back pain or hip pain, and there is no fracture, then this is unlikely to be because of osteoporosis. Rather, than other cause for the backache need to be sought. This is very common. 1 in 2 women and 1 in 4 men over the age of 40 will have an osteoporosis-related fracture in their lifetime. Here it is showing that there is tends to fall in easy fractures because this fracture from self height, this fall of the self height does not cause fracture until patient has osteoporotic bones. Because the bones are so porous, even fall from the self height leads to the fractures. In women, it is 3 times more common than men. Low peak bone mass. Peak bone mass is achieved by the age of 25 to 30. Maximum goes to the maximum levels. Then a gradual decline occurs. But why osteoporosis is so common these days, I believe we actually don't achieve the peak bone mass during our young age, maybe because of our diet not fortified with the vitamin D, because of use of lot of junk foods, and less exposure to the sunlight. All these predispose to the decreased peak bone mass achievement. Hormonal changes at menopause also predispose, and other cause are because since the people live longer these days, so this is more commonly seen than it was previously. Vertebral fractures and wrist are the more common in women. Now, this is how the peak bone mass occurs. It is much higher in cases of males as compared to the females. And then there is a, if you see the age is 30 over here, this is 30, and this is the peak bone mass that we achieve. After this, then there is a gradual decline in the mass. But this decline is steady in cases of male, while there is a huge dimple over here. This is because of the estrogen that usually decreases bone loss in postmenopausal women. Because of the absence of the estrogen, there is more quick decline in the peak bone mass in females. We have already mentioned achieved by 30. These genetic factors account for 40 to 80% of the differences. Calcium, vitamin D, and physical activity, all these count. Bone mineral matrix, calcium, vitamin D, phosphorus, magnesium, collagen synthesis, protein, copper, zinc, iron. Early pubertal girls, pint of milk per day versus nothing. All these predisposed to if increased bone mineral. If we take these in adequate amounts like calcium, vitamin D, phosphorus, magnesium, copper, zinc, and protein synthesis, because collagen is also needed for the bone, lead to increased bone mineral density, increased serum insulin-like growth factors. In the absence of these, if we don't take in the adequate amount, then probably we are not achieving the peak bone mass at a level what we are supposed to achieve, and as a result there is a quick decline and early osteoporosis. This is bone remodeling cycle. Pre-osteoclast, they activate the osteoclast, which leads to, these are the osteoclasts actually, bone destructing resorting cells, increase osteoclastic activity. And mononuclear cells, these inhibit the resorption. And here you can see the pre-osteoblasts are formed. This leads to the reversal of the osteoclastic activity, and then the osteoblasts further increase in number and lead to the increased bone formation. And then the bone which was lost because of increased osteoclastic activity now is formed and leveled. But this bone mass is still incomplete because mineralization need to be there. For mineralization, there are the osteocytes. These mineralize your bone. Otherwise, this area becomes vacant and works as a empty space, leading to early fractures. So mineralization of the bones in the form of calcium, vitamin D, zinc that we have just talked about is caused by osteocytes, leading to bone mass formation. So PTH initially is catabolic activity. when we give in the pulses, this also leads to anabolic activity as well. Imbalance remodeling in menopause leads to osteoporosis. Effects of aging, estrogen deficiency, increased bone resorption more than bone formation. So this balance is actually lost because of these. And when the aging process, estrogen deficiency, the balance which normally occurs over here, the osteoclast is balanced by the osteoblastic activity, is actually does not keep pace over here, so leading to innate bone loss and osteoporosis and early fractures. Here you can see the impairment in the bone mass and quality in osteoporosis. The strength of osteoporotic bone is impaired by loss of bone mass, reduction in the bone quality, loss of horizontal struts, loss of connectivity, conversion of trabecular plates to rods, resorption pits or stress concentrator, and unfavorable geometry. All these are the features of osteoporotic bones. While in younger normal subjects, you can see that there is much density in this meshwork of the bone structure. Primary osteoporosis is heterogeneous. Multiple mechanisms are found to be involved, and the postmenopausal, senile, or idiopathic may overlap with these. Premenopausal and younger men with osteoporotic fractures may have multiple causes that we have just discussed: celiac disease, malabsorption, gastrectomies, all lead to inadequate achievement of the peak bone mass, and as a result, what happens? The early fractures occur. Hyperparathyroidism also another cause, which also leads to any adenoma or a tumor in the parathyroid glands, leads to increased uncontrolled activity of parathormone, which we know drags calcium and minerals from the bones, leading to fragile and weak porotic bones. Treatable secondary causes are celiac disease by avoiding the gluten. Suspect when there is weight loss or chronic diarrhea, diagnosed by anti-TTG antibodies. Hyperthyroidism and other cause, diagnosed by TSH and FT4, free T4 levels. Vitamin D deficiency or insufficiency, get serum calcium, serum vitamin D levels. Extreme forms lead to osteomalacia as well. We have already mentioned. Hyperparathyroidism just mentioned, because it leads to the transposition of calcium and other minerals from the bones, and as a result, bone becomes fragile and weak and easy to fracture. Multiple myeloma. Hypothyroidism is diagnosed with serum calcium levels and PTH levels. Multiple myeloma also causes spine fractures above the T7 levels. Diagnosed with SPEP, serum protein electrophoresis. Paget's disease, another cause, is diagnosed with isolated increased alkaline phosphatase of the bone origin with other normal parameters like calcium, phosphorus levels. Cushing syndrome, another cause, can be iatrogenic use of steroids, is diagnosed with 24-hour urinary free cortisol levels. And medical non-compliance is diagnosed with urinary and terminal chylopeptide levels. Additional causes are hypogonadism in the male, decreased serum testosterone levels, early menopause or amenorrhea in females, rheumatoid arthritis, because chronic inflammation has been associated with early development of osteoporosis, because it is thought that it interferes with the osteoblastic activity. Inflammation inhibits the osteoblastic activity. As a result, bones become fragile and weak. Idiopathic hypercalciuria or renal defect, where increased calcium is excreted from the kidneys. This is diagnosed by increased urinary 24 urinary free calcium levels. Tumor-induced osteomalacia also occurs, which can be diagnosed with phosphates. When Z score and T scores, these are the scores we do for the diagnosis of osteoporosis. What these actually mean, if the Z score is less than -2, then the secondary cause is more likely for the osteoporosis. Secondary cause of osteoporosis are some drugs. Glucocorticoids are very well known, used commonly for different disease condition like patient with asthma or chronic obstructive lung disease. Use on and off glucocorticoids in the oral and inhaled forms. Patients with autoimmune diseases like rheumatoid arthritis, SLE, and other vasculitis are frequently given corticosteroids. These also predispose to the osteoporosis. Excessive thyroid replacement, thyroxine in excess leads to hyperthyroidism-like features and osteoporosis. Anticonvulsant drugs like phenytoin, sodium valproate also lead to the basically lead to the osteomalacia, but can lead to osteoporosis as well. Lithium is also known to cause. Long-term heparin use also predisposes to the osteoporosis. Gonadotropic releasing hormone agonists used for prostate cancer also cause osteoporosis. Aromatase inhibitors, which are used in patients with breast cancer, also predispose the patient back to the osteoporosis, because aromatase inhibitors inhibit the testosterone levels, which is required for bone formation, and as a result, decreased estrogen in the breast cancer patients also lead to the osteoporosis. So we are commonly referred patients by the oncology department who are diagnosed with breast cancers and underwent surgery, but then later on are put on aromatase inhibitors. Before that, we get dexaskin on these. Now, these are the conditions where even osteopenia, not the frank osteoporosis, if present on the bone mineral density dexaskinning, we start bisphosphonates in these patients, because we know further administration of aromatase inhibitor, because these are given approximately for 5 years. So the continuous administration of aromatase inhibitor leads to further decline in the bone mass. So we empirically treat these patients with the bisphosphonates. Methotrexate, cyclosporin A, some sedative-hypnotics are found to cause osteoporosis. Sedatives are more associated with the fracture risk because of sleep-inducing property. Total parenteral nutrition, which is not fortified, can also lead to early development of osteoporosis. Bone remodeling and causes of imbalance or bone loss. We have just mentioned. Increased bone resorption occurs because of steroids, decreased estrogen, hyperthyroidism, cytokines in the inflammatory conditions, as we saw that in the rheumatoid arthritis we already mentioned. These cytokines actually interfere with the osteoblastic activity and leads to increased resorption and decreased level of osteoblastic activity or bone formation. Bone mineral density is a major determinant of fracture. Here we see normal bone density is from -1 to 0 to up to +2. This is normal, even up to minus, but from -1 to -2, low bone mass osteopenia, where we call this osteopenia. From 2.5 actually, -2.5 to -5, this is osteoporotic range. So on the bone mineral density, normal, we have up to from -1, greater than -1 to +2 is the normal bone mass, while between -1 and -2, it is osteopenia or low bone mass. Between greater than less than 2.5 to less than -5, this is osteoporosis. These are the patients who have increased risk of fracture. Here you can see the risk is inclining, see the curve to that much high level when we reach the osteoporotic levels. So every effort should be made to avoid and screen the patients initially, and so that to avoid the osteoporosis and risk of fracture. These are all the factors which lead to the fractures. Hormonal imbalance, nutritional abnormalities, no exercise, sedentary lifestyle, these lead to decreased bone mass. Architecture and geometry of the bone also not up to the mark. Bone material strengthening not there, so low bone strength lead to fracture, plus fall at that risk of fractures, pedaling, postural reflexes. All are these are predisposing the patient to the fractures. How patient clinically presents in cases of osteoporosis? Usually a silent disease, but there is, if someone notes, there is gradual decline in the height because of decrease in height of the vertebrae because of this osteoporotic bones and compression fractures. This is normal bony architecture, reduced bone mass, and then the osteoporosis, more porous, large pores within the bone trabeculae. Sometimes low backache, usually mild, loss of height, dorsal kyphosis, and fracture, most common of the vertebral and hip areas. Here you see this is the compression fracture of the vertebrae. You see the height of this vertebrae and this vertebrae. When comparing to this vertebra is very much compressed. In a pectoral form, this is normal vertebral appearance. This is biconcave or cord fishing deformity. This is wedge fracture, and this is the typical compression fracture. So any of these may occur in patients with osteoporosis. Here you can see this is compression fracture. See the height of this vertebra, and this. So this is completely compressed, or compression fracture, what we call. This leads to the dorsal kyphosis and loss of the height as well. Here is also initially slight decrease in the vertebral height. This may be the initial feature. Again, you can see here the fracture at the metaphysis of the radius. Diagnosis is done through the bone mineral density using DEXA scan, dual energy X-ray absorptiometry. This is how we classify osteoporosis. Normal bone mass is -1 or greater. Then the osteopenia between -1 to -2.5, and osteoporosis -2.5 or less bone mineral density. And severe osteoporosis, this pilus of rigidity fracture, if occurs, this is labeled as severe osteoporosis. How the T and Z scores are interpreted. The T score is calculated by taking the difference between a patient's measured bone mineral density in a this point of time and the mean bone mineral density of young normal population measured for gender and ethnicity, and then by dividing the difference with the standard deviation of the bone mineral density of a young normal population. Means if we are getting bone mineral density or DEXA scan of a patient that is 55 years of age. We see what is the bone mineral density of that patient. Then we compare this with the same gender and ethnicity, where at the age of 30 years, what would have been the bone mineral density. And then how much deterioration from that peak bone mass has occurred at the age of 55. This is called the standard deviation, which is read in the minus the sign. Because what was the peak bone mass that was achieved at a particular time, that is 30 years, we achieved. Then we now compare the current bone mineral density of that patient with that of a 30-year from the same gender and same ethnicity. Then we see how it has deteriorated from that 30-year age up to the age of 55. This is given in a graphical manner, and also in the T-score is patient's measured BMD minus mean bone mineral density of a young normal population. The standard deviation of bone mineral density from the young normal population, how much standard is deviated from the that peak bone mass was achieved of a 30-year. Z-score is similarly calculated comparing a patient to age matched group. That is, Z-score is equal to patient's measured bone mineral density minus mean BMD of age matched group, and the standard deviation divided by standard deviation of BMD of age matched group. The diagnosis of osteoporosis is based on the T-scores, while Z-scores, if also concomitantly decrease, then the metabolic bone diseases like osteomalacia, renal osteodystrophy, other conditions need to be taken into account, Paget's disease. So for diagnosis of the osteoporosis, it is DEXA scan and a T-score. This is how we label the patient. This is normal, between -1 and -2.5 osteopenia, -2.5 or even less than osteoporosis. If osteoporosis -2.5 plus, there is a fragility or low impact trauma fracture. This is severe osteoporosis. Way to get in bone mineral density testing in women age 65 years of age and older, and men age of 75 and older. In postmenopausal women and men above the age of 50-69, based on the risk factor profile. If they have other risk factors like use of corticosteroids, rheumatoid arthritis, other inflammatory diseases. In postmenopausal women and men age of 55 and older who have had an adult age fracture, to diagnose and determine the degree of osteoporosis and its cause as well. Dual study facilitates using accepted quality assurance measurements of bone mineral density. Whom should we treat? Those who have risk for fracture. National Osteoporosis Foundation recommendation, old thinking, based on bone mineral density. T-score less than -2 without risk factor for fracture. T-score less than -1.5 with a risk factor. So if this is -2 or less, even no other risk factor exists, you have to treat the patient. T-score of -1.5, this is, remember, this is osteopenia. But if there is associated risk factor, like patient asthmatic with recurrent use of corticosteroid, inhaled and oral, patient is having a rheumatoid arthritis, patient with multiple myeloma or other conditions which we think also predispose the patient to the osteoporosis, need to be treated. And patients with CA-based, as I already mentioned, who are being put on aromatase inhibitor, if their bone mineral density is less than -1, still they need treatment. Newer thinking, absolute risk fracture. This is done with the calculation of the risk of fracture for the 10 years. Percentage of risk over the next 10 years. Calculation based on major risk factors. Treat the patient, not the T-score. So this is calculated using FRAX scoring system. Here, I will show you as well. Estimate the 10-year patient specific absolute fracture risk, hip or major osteoporotic fracture of the spine, forearm, hip, or shoulder. Evaluates the fracture risk from epidemiological data. Integrates clinical risk factors as well as BMD, bone mineral density, femoral neck, and incorporates into National Osteoporosis Foundation treatment guidelines and other country-specific recommendations. This is restricted to the untreated patients. Those who are already treated are not subjected to FRAX scoring system. This is FRAX scoring system. You have all the options: age, date, sex. Then we have the questionnaires, and based on gender, weight, height, previous fractures, parent history of hip fracture, current smoking status, glucocorticoids. So all these parameters are included, and then it automatically calculates the risk of the fracture for the next 10 years. So based on that risk, if the patient is moderate to high risk, then we treat these patients irrespective of their bone mineral absolute bone mineral density scores. So this is now more being implemented, and it makes sense as well, as we are not treating just the BMD scoring, but we are treating overall patient through a holistic approach. These are the treatment options that we have right now. Non-pharmacological exercise, balance, calcium supplementation, vitamin D, daily requirements, decrease alcohol, stop smoking, stop positive agents which are predisposing to the corticosteroids whenever possible, minimize the risk of fall at home, and use of hip protectors. These are all the things that can be done in order to avoid the fractures. But if the patient has developed osteoporosis and there is a FRAX scoring system showing the risk of the fracture that is moderate to high, then these are the treatment options that we have. Bisphosphonates, we have different types, oral form, injectable forms with weekly, monthly, 6-month and yearly regimes. SERMs, also selective estrogen receptor modulators, can also be used. Calcitonin, estrogen replacement, and rank ligand antibodies, that is denosumab. A receptor activator of nuclear kappa ligand antibodies. Denosumab is also used for the treatment of osteoporosis. Then we have these all have anti-resorptive activity, means these decrease the osteoclastic activity or bone resorption, while we have other options that increase the anabolic activity, which are teriparatide and strontium granulate. These are, we have already mentioned. Diet, good balanced diet with adequate use of calcium and vitamin D containing foods need to be encouraged. Anti-resorptive bisphosphonates, as I had already mentioned, these work through the decreased resorption or decrease osteoclastic activity, and as a result decrease bone destruction. These work here. So inhibit osteoclastic activity and thus bone resorption and increase mineralization of the existing sites. These are the options. Zoledronic acid reclassed, but here in Pakistan we have Aclasta, 5 milligram IV once yearly. Then we have alendronate, 35 milligram per week for the prevention, and for the treatment 70 milligram per week per orally or oral solutions, and the tablet form and the oral solution as well. However, all these patients who are being given bisphosphonates need to be treated with adequate supplements of calcium and vitamin D. Then Resindronate, Actonil, 35 milligram once weekly and 150 milligram once monthly. Regions which suits to a particular patient. Abendronate, the data is limited for extra spinal prevention of the fractures. However, spinal protection is good. So based on the weak anti-resorptive activity, this is less commonly used. I personally don't prefer this in patients with osteoporosis. These are the drugs which increase anabolic activity. Teriparatide, Forteo appears to create new trabeculae, increases osteoblast lifespan. Increase osteospan means increase bone anabolism, increase bone formation, and resorption for decreased resorption follows. Given as a daily subcutaneous pulse, the only adverse effect is its cost, and cumbersome is the daily use of injectable, which is not easy for all the patients. So here you see this acts as over here, it increases the osteoblastic cells and increase osteoblastic activity, bone formation, followed by mineralization of the dead bone and normal maintenance of bone architecture. Denosumab, it's a fully human monoclonal antibody, binds to rank ligand, prevents rank ligand from activating the rank. It's receptor on the osteoclast phase. Because rank ligand, when attaches to the rank, which is its receptor on the osteoclast, it increases the osteoclastic activity. So this is monoclonal antibody which inhibits rank from its attachment to the rank ligand, and as a result, osteoclastic activity is inhibited. With reduced rank ligand binding, osteoclast formation and functioning and survival are inhibited. As a result, bone resorption is decreased and formation increases. It is given in subcutaneous 60 milligram dosage every 6 months. These are the surgical corrections of the osteoporotic fractures. What clinical changes we have? Often asymptomatic. If we do not screen these patients, may go unnoticed and may land with catastrophic fractures. Even after some fractures, 2/3 of vertebral fractures are asymptomatic. The challenge to clinicians to identify a patient at risk for fracture and then refer these patients to the rheumatologist for prevention and treatment of the condition. Thank you very much. कोई क्वेश्चन वगैरह का कुछ होता है क्या तारिक? The T score and Z score actually, or the T score gives you the exact picture that how osteoporotic or fragile these bones are. While Z scores give you an idea towards the underlying cause of this weakness of the bone. So if only T score is decreased, then you might have idiopathic osteoporosis. But when concomitantly Z score is also decreased, then there is also some problem with the other causes related to the like metabolic bone diseases, Paget's disease, like osteomalacia, are the causes which lead to the osteoporosis. So remember, if only T score is decreased, we treat these patients as osteoporosis with anti-resorptive or anabolic drugs. If concomitantly Z score also decreased, then these patients might need treatment of the underlying cause, like treatment of the Paget's disease, treatment of the osteomalacia, etc. Uh, a question comes that what calcium levels are where to start calcium levels. Um, Calcium is normally tightly maintained in the serum levels, so hypocalcemia occurs very rarely. However, even at normal level of calcium, that is between 8.5 milligram to 10.5 milligram per day, uh, we need 800 to 1200 milligrams of calcium. Uh, um, Whether it is coming from the dietary sources or we are taking from the supplements. Everyone needs this amount of calcium on daily basis, even if his or her serum calcium levels are normal. This level increases, demand increases during pregnancy and lactation up to 1500 milligram in the pregnancy and 2 grams up to 2 grams in the lactating mothers. Uh, we have here question, can osteomalacia and osteoporosis coexist? Yes, these may coexist as well. As I already mentioned, if both T score and Z score are absent, then we do further workup. We get vitamin D levels, we get calcium, phosphorus, and alkaline phosphatase. If calcium is low to normal, phosphorus is decreased, alkaline phosphatase is high, and vitamin D levels are low, this patient is also having osteomalacia. And if bone mineral density index is showing the score in the range of minus 2.5 and less, then also osteoporosis. So in this case, we usually don't treat the patient with anti-resorptive drugs or bisphosphonates. We first treat the patient's underlying osteomalacia, that's metabolic bone disease, with vitamin D and adequate supplements of the calcium. And we repeat the bone mineral density. If it is normalized or at least has come to be in osteopenic range, we then follow this patient with the calcium and vitamin D supplements and don't treat the his or her osteoporosis. I hope I answered the question. Thank you very much.